Airway management. For a conscious casualty with no airway problems, no airway interventions are needed. For an unconscious casualty without airway obstruction, do the following. Place the casualty in the recovery position. The recovery position helps to protect against vomiting and aspiration. Use the chin lift or jaw thrust maneuver, or nasopharyngeal airway, or extraglottic airway. Cervical spine stabilization is not necessary for casualties who have sustained only penetrating trauma. For the conscious casualty with airway obstruction or impending airway obstruction, allow the casualty to assume any position that best protects the airway, to include sitting up. Again, use chin lift or jaw thrust and use suction if available and appropriate. The nasopharyngeal airway is well tolerated by a conscious or unconscious casualty without stimulating the gag reflex and provides some protection of the upper airway. A nasopharyngeal airway may be inserted, or if the casualty is deeply unconscious, then consider an extraglottic airway, or EGA. An EGA is fast, easy, and less likely to cause harm than endotracheal intubation. Extraglottic airways will only be tolerated by a deeply unconscious casualty. If an unconscious casualty without direct airway trauma does not tolerate an EGA, then consider only using a nasopharyngeal airway. Positioning or nasopharyngeal and extraglottic airways may not suffice for casualties with trauma to the face and mouth, or facial burns with suspected inhalation injury. For these casualties, a surgical cricothyroidotomy may be required. If the previous measures are unsuccessful, perform a surgical cricothyroidotomy. Options include the bougie-aided standard open surgical technique or the Cric key technique. Remember to use lidocaine if the casualty is conscious. Casualties with severe facial injuries can often protect their own airway by sitting up and leaning forward. Let them do it if they can. It would be almost impossible to intubate a casualty with this kind of injury, especially on the battlefield at night. Airway obstruction is the second most common cause of potentially preventable deaths on the battlefield, so you must be able to perform a cricothyroidotomy if necessary. Cricothyroidotomy is hard to do. Combat medics have often failed to get it right on the battlefield with a 33% failure rate. This is the most technically difficult procedure we ask medics, corpsmen, and PJs to do. Repetition and realism during training enhances skill development and knowledge retention. Combat medics should perform cricothyroidotomy at least 5 times during training on an anatomically realistic model. Remember, surgical cricothyroidotomies should not be performed on unconscious casualties who have no direct airway trauma unless use of an NPA or EGA have been unsuccessful in opening the airway. Always remember that a casualty's airway status may change over time and requires frequent reassessment. You should monitor the hemoglobin oxygen saturation with pulse oximetry to help assess airway patency. In the presence of moderate or severe TBI, hypoxia is associated with worse outcomes and should be prevented if possible. Casualties with moderate or severe TBI should be given supplemental oxygen when available to maintain an oxygen saturation greater than 90%. Remember, open the airway. Use positioning, nasopharyngeal or extraglottic airways, or perform a cricothyroidotomy, and reassess airway status frequently.